Good morning, everyone. Thank you for your participation in such early time here in Japan. And Chris, thank you for giving us this opportunity. We're so excited. First, I'd like to briefly introduce Dr. Christpher in Japanese. 皆さん本当におはようございます。ご参加ありがとうございます。クリス先生、ベス・イスラエル・ディーコネス・メディカルセンターっていうハーバードの教育病院の、内科のプログラムディレクターです。っていうのは、本当に、とっても信頼されて、臨床的にも優れている、で、教育に熱心な先生にしかなれないという、すごく、プレスティジアスな、ポジションでいらっしゃる先生ですので、今日は、本当に、教育について、指導について、興味深いお話が聞けることと思います。で、先生の方からご質問ありましたら、ごめんなさい、チャットでご回答もいただけますし、直接声を出していただいても大丈夫です。So Chris, I just said that the being a program director at the BIDMC is such a prestigious work, and that really speaks how wonderful you are.
Thank you so much, Dr. Takeda. It's such a delight to be with you all.
Right. So shall we begin?
Absolutely. Let me share my screen here very quickly here. Let's see here.
はい。で、皆様、これからレコーディングをさせていただきますので、よろしくお願いします。So Chris, I will start recording this lecture.
Can you all, well, let me reverse that. Hang on a second.
Mm-hmm.
Let me stop sharing. I have my screens reversed there. Give me 1 second. Nope. Sorry. One more time here. Let me get this right. Apologies. I'm not sure why this is happening.
Take your time. So while waiting, I just give a brief background for this lecture. はい。今回は日本プライマリケア連合学会の国際委員会の、プロジェクトとして、お届けしています。それから、皆さんに、日野原フェローシップという、フェローシップの存在を知っていただきたくて、提供しています。So you ready?
My screen share seems to be doing tricks with me.
Mm-hmm. Now I see the desktop screen. Oh, here you are, I think.
Does that seem right to you now?
Yeah, it's working.
All right. Unfortunately, can you see the full screen?
Yes.
Okay, great. Well, I'm so happy to be with you today, and I would love to have as much as possible this be a bit of a dialogue with us all. So I'm going to ask you at times if you wouldn't mind putting into the chat a couple answers when I ask you some questions. And as you go along, for your own information and learning, I would encourage you to find a piece of paper to jot down a few things that you hear in today's talk that you would like to learn, that you'd like to remember, and possibly incorporate into your own teaching in the future. And if there's certain that you're uncertain about that you'd like to learn more about, please feel free to jot that down, and you can ask me at the end as well. Throughout today's talk, I want us to think about what the very best teachers you've experienced over time are like. What characteristics have they displayed? I'm going to ask you that question in a moment, and if you wouldn't mind, I'd love to have you share with me your thoughts about that. And then we're going to spend a little bit of time thinking about the micro skills of clinical teaching and how do we optimize the use of those micro skills. So I know it's early, and it's hard to participate so early in the morning, but if you wouldn't mind closing your eyes for a moment and thinking about the very best teachers that you've had, particularly those teachers you've had in medical school and in the clinical setting, and think about what made those really exceptional teachers so good? Just close your eyes for a moment and think about that best teacher and what made them so good. And when you're ready, if you could just put just a word or two in the chat about what made them such good teachers. Put it up here so we can all see. Not just about knowledge, but teaching how to. So it goes beyond the knowledge. I love that. Being interested in teaching, passion, caring about learners. This is great. Thank you. A good role model. I love what you guys have said so far. That's wonderful. We have one or two more. Trusting. Thank you. That's really great. Let them think deeply. You guys, I'll tell you this already. I know that we're dealing with a very high level group, and you're not going to need me for this talk. You already possess all those skills that I think that make an outstanding teacher. But I do want to go to the literature for a second and think with you what the literature has to say makes the very best teachers. And they tell us that the very best teachers actually teach more. It's not that they're on service more or that they're in the clinic more often, but when they're with learners, they teach more. And we learn that the very best teachers come to teaching prepared. They oftentimes spend time in advance of their teaching, advance of clinical time, if possible, to get to know their learners, to get to understand their needs, what their desires are, and to think about what things they might be teaching. And this reminds me of a paper where this was described by David Irby. And David Irby, in his paper, he followed the very best teachers around and tried to understand what made them so good. And he found that these clinical teachers planned a lot in advance. They thought about who the learners were that they're going to be working with. And when the opportunity allowed, they thought about what sort of cases they were going to have. In the outpatient setting, that might be thinking the night before about what patients you and your learner might be seeing. On the inpatient side, it might be thinking about what cases have come in that your team would want to see, and think about how you're going to teach that. What teaching points do you want to make? And then at the end of the rounds, at the end of the day, they reflected on how the teaching went. And that reflection took back again to the planning part. And that's something we've discovered. The very best teachers do spend a lot of time thinking about their learners and the planning their teaching they're going to do. Studies show the very best teachers provide feedback to their learners. And oftentimes in my role, I have faculty that come to me saying they're afraid to give feedback, that it can be intimidating to give feedback. And yet study after study say that our learners really crave and want lots of feedback. And this last point, I think you guys so nicely highlighted in your comments in the chat, that the very best teachers are not necessarily the smartest people in the room or the ones with the most knowledge, at least not in the eyes of our learners. What our learners identify as the best teachers are those who stress the patient-doctor relationship and the psychosocial aspects of medicine. I oftentimes say that our learners will remember far more what we do at the bedside with them than what we say. We are such profound role models, and that's something that you used in your comments just a few minutes ago, and I thought it's such an important thing to remember, that we're profound role models for our learners. And when I think about this, I'm reminded of the passing of one of our legendary faculty here at Beth Deaconess Medical Center, who passed away a few years ago, Dr. Frank Epstein, who was a nephrologist. And Dr. Epstein had been an editor for the New England Journal. He had been a chair of medicine here. He published hundreds and hundreds of papers in nephrology. And at his eulogy, physician after physician stood up to talk about Dr. Epstein. And they didn't talk about his accomplishments at the New England Journal. They didn't talk about his research. They talked about remembering him going to the bedside and how he interacted with patients, how he would make sure the patient was comfortable before he did anything else, how he would fluff up their pillow for them before helping to examine them, or making sure that he warmed up his stethoscope before laying it on the patient's back. These are the things that they remembered about this great physician, and these are the things that our learners remember about us. And yet we know that we oftentimes make mistakes. We have lots of common pitfalls when we're teaching. We oftentimes answer our own questions instead of providing questions to our learners, or we break into inappropriate lectures instead of allowing our learners enough time to think about the answers and provide an answer. We teach at a level that doesn't really appreciate the learner's level of understanding, and we sometimes take over the teaching in this setting. This will leave our learners at the intersection of lost and confused because we're not really providing highly effective teaching. Instead of having synapses firing on them in a really powerful way that allows them to retain the information and hopefully retrieve it again in a meaningful way in the future. And this is where I feel that the micro skills of teaching, I'm sure we'll spend the rest of our afternoon or morning talking about, becomes highly effective. And there are 5 micro skills, which I like because it allows me to create a paradigm in my head about how to teach effectively. And this paradigm has been studied time and time again. And it shows that when we use this, we're able to diagnose our learners better, teach more effectively, and actually diagnose our patients better. And these 5 steps, which we'll go over in more detail, include first getting a commitment from our learner, having them outline and diagnose a plan of action. After we get a commitment, we want to probe for supporting evidence and question their reasonings so that we can better understand what they're thinking. We then want to teach in general rules, but only provide a few take-home points because we know they're only going to be able to remember a few points per case. We want to enforce what they did right and provide positive feedback. And of course, we need to correct mistakes and suggest what could be improved. And I'm going to approach these one by one very briefly and start with getting a commitment. And I suspect that you do this naturally already when you're with your learners. Getting a commitment is asking questions like, what do you think is going on in this case? Or how would you manage this? Rather than saying, clearly, this is a case of pulmonary embolism. Now, getting a commitment sounds very simple, but its roots are grounded deeply in adult learning theory. By asking that simple question, what do you think is going on? It activates our learner. It gets them to participate in the learning process. And it makes them feel more responsible for their patient care. I sometimes describe this as giving our learners the illusion of autonomy. We know they can't be truly autonomous, but that gives them a sense of it or an illusion that they're autonomous. And finally, it allows us to diagnose the needs of our learner. Now, this sounds really simple, but I'm sure you've been in situations where this is much more complex. You want to have your learner discover the right answer. You want to help them discover the right answer, but sometimes they struggle at that. I'm going to give you a brief example. You've probably been here before. You send a learner in to take the history from a new patient that's come in, and you tell them, I want you to take a history and come back and present it to me, and we'll discuss the case together. The learner goes into the room, and 5 minutes, 10 minutes, 15 minutes goes by, and you're wondering what exactly happened. 20 minutes later, the learner comes out, and they present the case to you. But you can tell from their presentation, they don't really know what's going on. It's a bit messed up. It's combobulated. They don't have all the facts really straight when they're talking. And it makes you nervous that they're not going to be able to come to the right diagnosis like you want them to. And there are lots of ways to approach this sort of scenario. You may say, tell me, what was the main concern our patient had? Or what's the most worrisome thing that you heard or learned our patients say? And another technique that I like to use a lot in this situation, which helps our learner discover the answer, like giving away, is to ask permission to restate the facts. So you might say, I hear you that our patient had a lot to say this morning. Do you mind if I just restate what you told me to be sure that I understand all the information so that I have the facts correct? So if I hear you correctly, our patient is a 52-year-old female, and she's taking oral contraceptives and she smokes. And if I understand you correctly, she just flew back from Boston to Tokyo, where she'd been visiting her family in Boston. And now, if I'm hearing you correctly, she's presenting with pleuritic chest pain and shortness of breath. Does that correctly give the story? And you almost see their eyes light up. And they say, yes, that's exactly what I'm saying. I think my patient has a pulmonary embolism, right? And you didn't tell them that. They said the words themselves, but you just lined up the facts in a way that let them continue to discover the right answer. Now, oftentimes, if the learner will commit to an answer, I'm thrilled and I'm ready to move ahead, but I need to stop and probe a little bit more. Because when I probe, it engages and it stimulates the learner. It helps them reflect on their clinical reasoning and get them to think out loud. And by doing so, you can identify knowledge gaps and help them role model and allow you to role model clinical reasoning. And this could easily be done by saying something to the effect of, well, I agree with you that our patient has a pulmonary embolism, but what major findings led to that diagnosis? Or is there anything else that we should consider? Or the one I like the most is oftentimes saying that I agree with you that our patient probably has a pulmonary embolism, but could you share with me what was number 2 and number 3 on your differential diagnosis? And what made you push them down to number 2 and number 3 and a pulmonary embolism up to number 1? And by doing this and probing for supporting evidence, you really understand what they know and they don't know, and allows you to teach at the right level for them. But by asking these questions, you're also moving up Bloom's taxonomy. And that we know that when we ask questions that go beyond simple knowledge, when we ask questions that ask them to analyze or synthesize their information, then we're having them go deeper into their thought processes. And when you do that, the information becomes stickier. It makes it easier for them to retain that information and retrieve it again at a future time. And to get to the higher levels of analysis and synthesis, I oftentimes think about, well, what exactly is the question that I'm asking? I try to move beyond the top level question here, the factual question. And sometimes I ask them questions that makes them broaden their thought process. What are the other causes of this patient's abdominal pain that we haven't thought about so far? Sometimes I may make it a hypothetical question. What if I told you that our patient were immunocompromised? How might that change your diagnosis? Or what if our patient here who has pleuritic chest pain, what if I told you that the chest pain got better when they sat up and was worse when they're lying down? How might that change your thought process? Now, as we're doing this, the key to this partly is to keep all these questions in the learning environment they're creating here in this quadrant. Because we know that when our learners are excited and happy to be there, that we know that's the most effective quadrant for learning and most effective quadrant for feedback. But that can be challenging, right? We know that asking questions of our learners can sometimes be intimidating to them, and they can shut down and not want to participate. So I'm going to ask your participation again in just a moment. I'm going to tell you a brief story about how this happened to me one time. But as I do that, I want you to think for yourself, how do you ask questions of our learners in a clinical setting in a way that helps them feel supported and can feel that they're in a safe learning environment? Let me tell you a brief story about how this happened to me one time. So here in the US, I was a third-year medical student doing my core clinical rotations. And in one of those core clinical rotations, I was in the operating room doing my surgery rotation. And as a medical student, I imagine in Japan, medical students probably do the same thing they do here in their surgery rotations, and that's hold retraction. And I was holding retraction during an upper abdominal surgery. And the surgeon turned to me and said, "So, young Dr. Smith, tell me, what muscles keep you on a horse when you're riding a horse?" Ooh, I had no idea. We were doing upper gallbladder surgery. I had no idea what muscles kept you on a horse. I'm sorry, sir, I can't remember what muscles. What do you mean you can't remember what muscles keep you on a horse? I'm sorry, I did not prepare for that today. Did you take anatomy? Yes, sir, I did take anatomy. Did you fail anatomy? No, sir, I got an A in anatomy. How are you here if you failed anatomy? No, sir, I got an A in anatomy. And it went on, and people in the operating room were giggling at it. And I realized that this was just something that he did to humiliate the learners. And I'll tell you to this day, I still don't know what muscles keep you on a horse. I was not at all motivated to learn that. Instead, I just wanted out of that operating room and I didn't want to be in there. So let me turn it back to you. If you wouldn't mind, again, sharing in the chat, as you guys did so well before, how do you keep a safe learning environment when we know that it's important to ask lots of questions of our learners? What do you do? Give feedback individually. Great. So try not to put them on the spot. Try and give them in a private location so they're not humiliated in front of others or embarrassed. Thank you. What else do you do? How else do you keep a safe learning environment? Making good relationships. I can't overstate that. It is so much about the relationships that you make. Ask how they feel first, which is part of having that great relationship. Ask them how they're doing. Get to know them a little bit as well. We can say our true feelings. So if we're open and supportive of our learners and we share our own deficiencies ourselves as the physician, smile. Thank you for saying that. I think that enthusiasm goes a long way in smiling and using the learners' names. I love that. Normalizing what they do not know and affirm what they did. I oftentimes will start by saying, I don't know everything. That's why I love medicine. I'm always learning. And it's okay for you not to know everything. That gives us a chance to learn things together. That was great. Thank you guys for sharing that. I'm going to share just a few things that highlight what you all just said so well. And that I think first thing to do is to show your own deficiencies, as you guys said, as you guys talked about earlier, role modeling. And here it's role modeling, being a good learner, as you guys nicely said. I try to avoid saying wrong and humiliate them. Somebody said nicely, give them feedback in private. Sometimes, so we talked about the case earlier, I try to reword what they're saying to help them discover the right answer, to help them help understand why they gave the answer they did, so that we can come back to it in a different way. I love the smiling because I think that enthusiasm is so important. If you can't be enthusiastic about what you're doing, there's no way our learners can be enthusiastic about it as well. In the United States, we have debates sometimes. I'm not sure if you have the same debates about this idea of what we call a cold call. Dr. Takeda, can I pick on you for a moment here?
Yes.
So a cold call would be if I turned to Dr. Takeda and I said, Dr. Takeda, can you please give me the key EKG manifestations of hyperkalemia? Right, don't answer that.
Okay.
But that would be a cold call, right? There are different ways of asking that question. There's something that's called a pose, pause, and then some people will say pounce. I don't like the word pounce, but I say pose, pause, and then ask somebody. So that question could be asked differently. So if you had a group of learners and you said, I'd like you guys to think for a second, in our patient with hyperkalemia, what EKG manifestations might we expect? After I wait a second, then I can call on Dr. Takeda and say, Dr. Takeda, would you be willing to share with us your thoughts about that? Right? So that's gives a moment pause so the other learners and Dr. Takeda have a chance to think together about what the right answer be before they're being called upon. Another way to think about that is a warm call. Cold call is if I just call somebody out. A warm call is giving a heads up and saying, in just a moment, Dr. Takeda, I'm going to ask you to help give a differential diagnosis for Ms. Jones here after she gives her presentation. And Dr. Yamanashi, I'm going to ask you to think through with us what the next step is in the care of this patient. Right? And by doing that, I'm giving them a heads up that they're going to be called upon in a little bit, but now they have time to think about it, and it's much less of a cold call. And then, as some of you identified, I think that it's important to use the learner's name and get to know the learner. And I'm going to come back to that idea of getting to know the learner in just a moment as well. Okay, so far, we've only really been talking about preparing to teach. We've not actually decided to teach yet. And we could do a whole talk on nuances of how to teach, but I really want to highlight just a few things. The first is, remember that your learner per case is only going to be able to retain a little bit of information. So I think about providing just 1 or 2 key take-home points during your discussions. But maybe later, come back to it in a different setting and revisit it and ask those what-if questions. What if I told you this patient's EKG changes weren't just in leads 2, 3, and AVF? What if I told you that this patient had ST changes throughout the EKG? How might that change your thought process? Again, those what-if questions expand their thought process and helps them develop a deeper learning in the case. Okay, I'm going to ask you a multiple choice question for a second, and I'm going somewhere with this. Trust me for a moment. I want you to think about this question. And it's a true statement that the most elite World Cup soccer players are born in the first 3 months of the year. Can you put in the chat your answer? Is that because of A, there are certain astrological signs that confer superior skills? B, are babies born in the winter have higher oxygen capacity? C, soccer fans are much more likely to conceive in the springtime, which is peak soccer season? Or is it D, none of the above? So just a quick, fun tangent, if you could just put an answer in the chat. C, I like it. C's. C's a popular answer. A D. All right, somebody's going against the trend, a D. So more D's and C's. So the correct answer is indeed D. I'm taking this from Dubner and Levitt, who wrote Freakonomics. If you've not read the book, it's a fun book. And this really gets at something that is about feedback. And I'm going to come back to why that is about feedback in just a minute. So it is true that the elite World Cup soccer players are generally, most of them are born in the first 3 months of the year. And across Europe, they create their elite teams, their youth teams, based on a calendar year. So players born in January, February, or March are on the same team as kids who are born in November and December. Now, when you're 26 and playing for the World Cup team, that shouldn't matter so much. But if that girl that is playing on that 8-year-old team is born in January and February, it's likely that they're going to be a little bit bigger, stronger, and faster and more agile than the girl that's born in November or December. Now, that shouldn't make a difference, but what it turns out is that the coach ends up providing more feedback to that better player. It's not that they stay better, it's what happens with that talent. And I used to coach my daughter's soccer team, and I found myself doing the same thing. There was Kate on my daughter's soccer team who was born in January and February, and sure enough, she was a little bit better, a little bit bigger, a little bit stronger and faster. And I'd find myself, as Kate would come off the field, giving her a little bit extra feedback, coaching her on a particular technique that I wanted her to go out and do. And this is this is why the answer is none of the above. It really has to do with what we do with those better players and the feedback that we give. What we're really creating is deliberate practice. And we find that this is really the key to success, more so than the 10,000-hour rule that we've read about. We believe that true success comes from deliberate practice, which involves setting goals, obtaining immediate feedback, and concentrating on technique. And I like these 2 quotes that remind me of this, that expert performers are made, they're not born. Acquisition of expertise requires sustained, deliberate practice over years. And one of the fastest ways to improve performance is to improve feedback. And this is how Naomi Osaka goes from the practice courts to this, where she's winning her 4th Grand Slam of the Australian Open. And this is how we go from the simulation center into the OR or to the clinical arena where we're successful. And I've always had a firm belief that positive feedback is the most important part of feedback. I used to say that giving positive feedback is making deposits into the feedback bank that you can make withdrawals later from. And I had long had this rule that you should receive twice as much positive feedback than negative or constructive feedback. because when you do that, it builds trust and support. Now, I said that this was a non-evidence-based rule. I pretty much just made this up myself, and I believed it to be true until I found this article in the Harvard Business Review. Even though the Harvard Business Review is a business journal, it has lots of great medical education pearls. And from this one, I learned that the right ratio of positive feedback to constructive or negative feedback wasn't 2 to 1 like I thought. It was actually 5.6 to 1. And I love this quote that only positive feedback can motivate people to continue doing what they're doing well and to do it with more vigor, determination, and creativity. Now, this doesn't mean that I need to tell Dr. Takeda 5.6 times what great things she's done before I can say something that she needs to improve, right? I don't need to tell Dr. Takeda, that was a wonderful differential diagnosis you created. That's 1. You did a great job counseling your patient today. You used very simple language and spoke to the patient in a kind way. That's 2. And when I get to 5.6, I can actually say something negative or constructive. But what this really is getting at is something you all identified at the very beginning. It's about developing a relationship with your learner. And when you have relationships with somebody and that person has faith and belief in you, then they're much more likely to receive negative feedback in a constructive way. Now, I could talk all day about feedback, but I really want to highlight just a few bullets here. Just like negative feedback, that when we give positive feedback, it's best given in a specific and timely way. To say strong work and nice job is good, but to say by keeping a broad differential and carefully analyzing all the data, you were able to make the correct diagnosis. That's far better. It's specific and timely. And I frequently will walk around with my teams, and as we're walking from one patient to another on the inpatient side, I'll pull back the intern and give them positive feedback about what they did. And they're usually shocked. They're like waiting for something negative. And I'll stop with the positive feedback and say, that's all. I just want to let you know how impressed I was by that one thing you did. That goes so far in building trust with them that you can then in the future start to correct mistakes. Now, sometimes you have to correct mistakes immediately, right? You can't let mistakes go untended. But if you have a chance to build that relationship first, it's more powerful. And again, we could do a whole talk thinking about correcting mistakes, but things I would encourage you to do is to allow your learner to first critique his or her own performance. If you've built the right relationship with the learner, I find that 95% of the time, they actually identify what they need to improve on their own. And when you do identify it, help describe what was wrong, give them a chance to correct it. Tell them what they need to do better to improve. And I tell my learners that feedback is what allows us to remain on course for our goal. That feedback is like sailing when the wind is not at your back. In that situation, you have to tack back and forth to get from point A to point B. And I think of that as feedback. It's tacking back and forth to get to our learners to where they need to go. I'm just curious if many of you have heard of the expression, the hidden curriculum. The hidden curriculum refers to elements of our curriculum that aren't expressed clearly in a written description. So the written curriculum would say our learners should learn how to do a good history and physical examination. They should learn the differential diagnosis for a patient who has a fever. They should be able to manage patients who have endocarditis. But the hidden curriculum are oftentimes those things that our learners must somehow acquire through osmosis. They acquire these skills by watching us. They acquire these skills by being around us. And this goes back to what you all said at the very first point about being a role model. And I would argue that you are the most powerful role model that our learners will have. Your ability to role model skills like communication skills, compassion, and enthusiasm is of the utmost importance. Now, the problem I have with the hidden curriculum is that, at least in the United States, the hidden curriculum has taken on a negative connotation. The hidden curriculum is oftentimes here referred to those times when maybe you didn't do the utmost best in your care. Maybe you were short with a colleague. Maybe you didn't spend as much time with the patient as you could have, or demonstrated as much compassion as you could have. And I dislike the idea that the hidden curriculum is actually hidden. I would far prefer for us to bring out the hidden curriculum so that when we're at the bedside, we call out the things that we see happen. Because when I'm with my learners at the bedside, I see amazing care every day. I see care that our nurses and physicians and technicians provide that's exceptionally kind and compassionate and thoughtful. And I ask my learners to call that out. And I'm going to give you a brief example. I was at the bedside with a team a few years ago, and the intern and resident were asking the patient some questions about their health. The patient wasn't having anything to do with it. The patient folded his arms and looked down and wasn't answering questions. The intern looked at the resident and was kind of like, I'm not sure what to do. The resident tried asking a few questions. Patient wasn't having anything to do with it. Arms were bent, head was looking down, not paying attention at all to them. The attending stood forward, walked from the foot of the bed to the head, pulled up a chair and sat down at eye level with the patient, and looked the patient in the eyes and said, Mr. Jones, if I remember correctly from your chart, you used to work at Fenway Park. Fenway Park here in Boston is a famous baseball park where the Boston Red Sox play. The patient looked up just the slightest amount and said, yeah, I did. The attending went on and said, and I saw that you worked there in the 1950s and 60s. Is that correct? Yeah, I did. The attending went on a little bit further and said, now, the 50s and 60s, some of the real legends in baseball came through Fenway Park then. You must have met some famous people, didn't you? Yeah, I did. He looked up a little bit more. He's like, who is the most famous person you ever met? I met Teddy Baseball. I met Ted Williams, who has long been viewed as the best hitter in American baseball. And then he smiled and he opened up and they talked about baseball for a few minutes. And after about 30 seconds of baseball talk, he opened up and started talking about what was bothering him and what was going on. The team was able to take a full history. And as they started to move on to the next patient, they talked about the patient's mitral regurgitation and what they needed to do. And they were about to walk on to the next patient. I said, wait, just 1 second. Before you leave, can we talk about what happened to the bedside there? And I had them identify the hidden curriculum. I had them call out what happened there, how the attendant had pulled up a chair and engaged the patient in a way that was important to the patient and made them feel important and valuable. And by doing so, they role modeled what was important in the care that we provide. They uncovered the hidden curriculum. And it reminds me of these two quotes from Albert Schweitzer, who said, example is not the main thing influencing others, it is the only thing. And Charlie Hayden, a colleague of ours here, who says you cannot not teach. You're always teaching and you're always a role model. And one thing I love about teaching is that we never know where the impact of our words and our actions as a teacher will go. I'll end with this one brief example of this as a teacher. And this is not a teacher who is a physician. It's actually my wife. My wife is an elementary school teacher. After she got her master's degree, she asked to teach in the most challenging school. She was teaching in a high school that was very difficult. And she would come home at night saddened because she had not made an impact in the lives of her students. We later moved from there and we came here to Harvard, where I was able to train. And several years passed, probably 7 years later, she got a letter in the mail. She didn't recognize the address. She opened up the letter, and it was from a student that she had taught many years before. That student's letter said, Dear Miss Smith, I wanted to let you know that I graduated from Humes. That was the high school where she was teaching. And I went on to junior college. I've since joined the military, and I'm a lieutenant something or other in the military. And I'm getting married next week. And I wanted to thank you. Because of you, I finished and I was able to get to where I am now. And what's amazing about that story to me is my wife didn't remember her at all. It was not somebody that she had mentored for weeks or months. It was somebody where a simple word or an action or a deed made an impact in the life of that person. And I think that is the same power that we have in our clinical realm as we have in our teaching realm. And I applaud all of you for the clinical care that you provide and the teaching that you provide, because both have a deep impact on the lives of another human being. I want to applaud you all for joining in this morning so early in your day. And I'll pause and take any questions that you have. I know you're probably eager to get on with your day, with your tasks, but I also wanted to thank you all for your kind time and attention.
Thank you. Thank you very much, Chris. I feel so moved. And thank you very much for sharing your passion of teaching and also reminding us how great to be a teacher, effective teacher. So I'd like to take this moment to get a question. ご質問、チャットに書いていただいてもいいですし、直接もうこれだけ、現在28名の参加なので、直接お声を上げていただいても大丈夫です。日本語でも英語でも大丈夫です。So I just said that they can write in the chat the questions or just speak up in English or Japanese, either way. So in the chat, I think Dr. Asakura made a small comment about smiling to the learners. Asakura,
Yes, I have. So I have two questions about. So thank you for your lecture, very interesting, and I was so impressed. And my first question is about the relationship between trainee and the teachers. So I am working at a very small clinic, but I continually accept trainee from the hospital, and there are a lot kind of trainees, excellent one and not so bad, and sometimes are some tricky one, and especially trainees are not motivated. So as you mentioned, so I think role modeling is good for training for teach them, but I think it takes a little bit time. So I'm tried, and also that involved so other professionals or nurses or some clerks are involved into such a situation, and it is not so easy. So I want to hear much more comment about some tips to promote their role modeling for such tricky guys. And another question is so about another fellows that are not motivated about an education. So between the trainee and the teachers, there are some relation that trainers should teach trainees. There is some relation, but for other fellows, so someone are motivated enough to teach younger generation, but not some are not so much, but they are needed to promote education effectively. So, but so some so in that case, so I want to involve all doctors into education more effectively. So yeah, so please give us a comment about that.
Dr. Asakura, I want to make sure I understand your question first. Is your second question, I think I understand, is when you have fellows who maybe they're with you, about engaging them potentially in the teaching process as well. Is that correct?
Yes, that's right.
I completely agree with that idea, because it's challenging sometimes when you have learners at different levels.
Mm-hmm.
And I think it can be really powerful to take some of the more senior learners and give them a chance to be more engaged in the teaching process. And I think it can be helpful sometimes to set that as part of your expectations when you go into the teaching environment, so that you can help coach the fellow and maybe give the fellow an idea of what things they might want to prepare.
Mm-hmm.
Now, it helps to allow them an opportunity to prepare their teaching. So if you say, I know that tomorrow we're seeing this patient who has adult Still's disease, and I would love for you to be able to provide a few words of teaching to our younger trainee about adult Still's disease, so you can prime them and prepare them and give them a chance to shine. Oftentimes on our inpatient wards here, we have designed a structure such that our interns, our first-year residents, and our more senior second and third-year residents are in a dynamic, and I say, I want the two of you to be the true care providers. And myself or the attending, I'm going to be your consultant. So I want the two of you to be doing the learning and teaching and patient care, but I'm here for you. I'm going to step in when I want to correct something or redirect something or provide a specific teaching point. But I want you to have a discussion amongst the two trainees and only reach out to me when you need me. But trust me, I'm going to reach in when there may be issues or concerns. And so I think it'd be really powerful. Now, if I understood your first question, it was, what do you do if you have a trainee who's less motivated? Is that?
Yes, that's right.
Yeah, that can certainly be challenging.
Yeah, challenging.
I think that part of that is getting to know your learner and understanding, what are your goals? What do you hope to get out of this? Setting some clear expectations early on. I'm going to ask you lots of questions during this time together. This is how we learn together. And I know that you're more interested in obstetrics than general medicine, but what I understand is that you're going to be dealing with these sorts of issues in obstetrics, even though you're not interested in general medicine. So I want to make sure that you understand these concepts, because you're going to have women who are pregnant coming in with these disease states, or whatever they're interested in, showing them the relevance of what they're learning here to what their future career is, or understanding why what they're learning here will be powerful for them going forward. Are a couple of techniques that I try to use.
Thank you. Thank you so much.
Thank you for the great questions and responses. では、小口先生、増美先生、we have another participant to ask a question. お願いします。
ありがとうございます。Thank you, Dr. Smith. I'm a resident doctor in Japan, and I'm really interested in education, and I have just started learning skills of teaching, like as you had a lecture about it. And yes, through the series of lectures for chief resident, and I really realized how it is important to learn like those skills when we teaching. But I think I really think that I should have been taught more about those skills while I'm in university, or I was a medical student. So, and in Japan, I don't think many like attendants and faculties are not really interested in education and do not know like skills to like for effective education. And I feel like many Japanese senior doctors think that education is a kind of frontier. It is not like we are not giving any incentives, or we do not have given like extra time for teaching. And in my understanding, all doctors I know in the US have a high skill and high quality of clinical education. My question is, in US or like other countries than Japan, how do doctors learn those skills? And when they learn those skills, like for example, in university, or like maybe the training to be an attendant?
Dr. Oguchi, thank you for your question. I appreciate that. And I would say that it has not always been the case that medical education carried the sort of importance in our training here that well, two things. One, it is not across all institutions in the US that it carries this sort of importance, or all disciplines in the US that it does in some places. I am fortunate to work at a place where people care a lot and think a lot about how to teach and how to be a better teacher. When I was first going through my training and I was in your shoes, it was not an area of particular emphasis. It was felt that, you've been in school for a long time, you've seen teachers teach, you must know how to teach. And it was really only when I was a very young faculty member that we started really thinking about how we teach better. And that I learned how to do that. We run a fellowship here for faculty to develop their skills as educators. We do lots of talks like this. We run a course on medical education. We just finished one 2 weeks ago where we had about 200 faculty from across the country come and join and develop their skills along these areas. And I believe that developing those skills, it goes beyond just a kind of a nicety of learning how to do that. We did a study a few years ago because I wanted to see if you develop your skills as a teacher, do you improve your skills as a clinician? And it turns out that there were lots of parallels, that a lot of the ways that you think about being an effective teacher helps you to be a better physician, clinician, and care provider. So there's lots of overlap between being a great teacher and being a great physician as well.
Thank you very much.
And I do hope that our association, Japan Primary Care Association, will provide you more opportunities to learn how to teach and encourage you to be a great teacher as well. Thank you. Right. So any other questions or comments? So desu ne. Well, I took a liberty of asking Otaki sensei to make a comment. Otaki sensei, もしよかったらご感想お願いします。
Okay. Nice to meet you. I'm Professor Otaki of Tokyo Medical University. I really was visiting research fellow of Deaconess in 96 to 97, and Ken McMahon was my colleague there. Also, he was a research fellow there, and I appreciate your teach and your comment about question, and I also agree with many participants here that the opportunity to learn teaching, especially in a clinical setting, is very rare here in Japan, and many good teacher was, I think, have been trained by themselves, not systematically. But I also think that the situation is gradually changing. Yeah, also here in Japan. So I'm very glad that many participants are eager to learn and understand the situation of not only the contents of your lecture, but also the situation of your medical education kind of society up there. Anyway, thank you very much.
Well, thank you very much.
Comment.
And Ken Muckamal is a gem of a person. He is a wonderful person, and always somebody I've looked to with a lot of admiration. And I was an intern here in 1996, so we may have crossed paths at Beth Israel in 1996 into 99. So we may have crossed paths then. But I would be, I look forward to hopefully having more discussions with you all, and happy to think about, how we can think about medical education in a systematic way with you all as well. Thank you for the invitation and the opportunity to be here.
Thank you.
Thank you very much. I think we this will be the time to conclude. But before I do that, I just take the liberty of saying that Dr. Muckamal, just Dr. Smith mentioned, she gave us the idea of this series of lectures. And he is the director of the Hinohara Fellowship at the Beth Deaconess Medical Center. I just put a link to the chat that we are recruiting a candidate for the fellowship next year. And please consider to apply or share this information so that you would have a chance to be at the Beth Deaconess Medical Center in an environment that the teaching is really considered the really valuable asset for the clinicians. はい。in Japanese。はい。皆さん今日はご参加ありがとうございました。本当にこんなにたくさんの方が朝早くにご参加いただけるとは思っていただかったので、本当に嬉しいです。今お話のあった向丸先生が、このシリーズ始めたらどうかというふうに提案してくださったんですね。で、今、その向丸先生がディレクターをしている日野原フェローシップで、1年間留学をする、プライマリーケアの教育について、学んでもらうフェローシップを提供していますので、よかったらぜひご検討ください。So thank you. I just announced about the Hinohara Fellowship that we are recruiting the candidate. And I believe we will have this second lecture in January. I don't think we have come up with a date yet. I guess we should have, so sorry. Yeah, but I hope that you would join us again. And I really appreciate this great lecture. And luckily we are given a privilege to record it. So please share this event with your colleagues and teachers. And so that we all learn how to effectively teach. はい。では、終わりたいと思います。感想ありがとうございます。もしよろしければ、ですね、山梨先生が Google フォームに感想を書いていただく、サイトを用意してくださいましたので、山梨先生すみません。リンクをチャットに貼っていただけますでしょうか。
今貼りましたので、簡単なものですから、よろしくお願いします。
はい。で、もし、お差し支えなければ、お名前とかメールアドレスとか書いていただければ、次回も必ず、情報が、届くようにしたいと思います。はい。その他、小林先生大丈夫でしょうかね。お伝えすることは。
はい、特にありません。今日はありがとうございます。
Hi, thank you. So, the question, because you mentioned that the feedback is very important, we quickly prepared the survey form, how they liked this event, and I encourage them to fill in and share the recording with their colleagues. Yeah.
Wonderful.
Yeah, thank you very much. 本当に皆さんありがとうございました。良い一日をお過ごしください。Have a great day to my colleagues and have a great night there.
A wonderful day, everybody. Thank you.
Thank you very much. ありがとうございました。そうですかね。So I counted the participant and the 28, we got 28, including our